Good morning. So, guys, we are, I can see we have 2 minutes to start our session. In the meantime, do you have any concern, any question, anything which bothers you? If there is any such thing, please write on the chat box so I can answer you. Because I learned this thing before starting your new session, always take a feedback regarding the previous session and what people are they are encountering anything. Why are the old kidneys in kidney transplant not removed? Yes, Khaled, I like your question. Excellent question. I wish you could have written this question in the class discussion. It could be benefiting everybody, but please write it there. I'm giving you answer at the moment because the new kidney we are transplanting, that is not in the same location. It is not in the same location. We will put in the right iliac fossa, right or left iliac fossa. Let's say if we are putting doing for right kidney or left kidney, so we'll keep in that location and we'll keep the old kidney as it is, because you never know this new graft which you have been placing, will it be functional or not, and then still you have something which can be utilized with the help of the dialysis and other things. So this is still in need, because removing that, keeping that will not give make any change. So because the new kidney will not be placed in the location of the old kidney, the broken kidney may work again. It Faris, it will not broken, it will not work again, but at least we have a connectivity and we can use it for something, but not necessarily it will not work, because if it's worth working, it could have been why we need to go for a transplant. This is a long discussion. I think we'll talk a lot about these things during the clinical anatomy session if time allows me, because I can see there is so much material, so many things. So I think I same here, Faris. It's my passion. So I think it's the time. So I should start sharing my screen with you guys, because I cannot afford to take my time. Guys, if you have questions, please park your questions and I'll try to come over, not during the presentation, because otherwise we'll leave so many things. So today we'll be talking about prostate and urethra, and these are my objectives. You can read it yourself. I need not to read the objectives. Now, my first slide, it says we have to compare the genitourinary system in case of male and females. And you can see in this image, what I'm trying to show here, let's take the first. So this is the male sagittal section, which is showing you what the placement of the organs in the male pelvic cavity. We are good with that if I say this is pubic symphysis and this is linea alba. This is urinary bladder and this is urachus. And you can see the cavity of the urinary bladder. You can see the opening of the ureter. You can see this is the place from where the urethra starts. And just behind the urinary bladder, you can see there is a seminal vesicles. There's a space in between, and there is a rectum. And rectum continues as the anal canal, and you can see its sphincters. Now, just urinary bladder, a big ovoid structure is sitting on a small structure which is walnut in shape. I'm sure everybody knows what is a walnut. And you can see that the urethra pierces through this prostate, and someone else is also piercing through from the posterior aspect, and that is nothing but this is ejaculatory duct. And the vas deferens, they are connected with the seminal vesicles, and then from there the final outcome is this ejaculatory duct. This is one, we have two ejaculatory ducts, and they are opening, they are connected to the prostatic urethra. And then this prostatic urethra, it continues its journey. It passes between this muscle. Can you see these two tiny muscles? So this, when the urethra reaches at this place, we call it membranous urethra. And then this whole length is the spongy urethra. The spongy urethra, for our convenience, we divide it into bulbar and the penile part. I'll be talking in detail in my upcoming slides. And just before the external urethral orifice, you can see there is a big space here. We call it navicular fossa. So these are the major visible obvious features. And one thing, if I don't mention it, it is not good. There you can see you can see so many veins here. So there's a bunch of veins and they are surrounding this prostate. So we call them prostatic venous plexus. So we can see a lot of them. So this is regarding the male organization of genitourinary system. In males, we don't have separate orifices, we don't have separate openings. So urethra serve the purpose of drainage of the urine and drainage of the seminal fluid. So sperm and seminal fluid and the urine, they passes. Now when they are passing, what are the mechanisms who prevent this mixing? That is really important, and this will be learning today. Going to the female side, now you can see most posterior structure after the sacrum, we have the rectum, same like men, and then there is something in between. Otherwise, all is the same. If I start from the front, same pubic symphysis, same linea alba, same urinary bladder, and same urachus. But the urethra is very short. Look at this urethra and look at this urethra. There's a gross difference between the two urethras. The female urethra is very short. But we have one additional structure, that is the uterus. You can see that, and this uterus is leaning over the urinary bladder, and then you can see on the sides, you can see the tubes and ovaries and everything. We're not talking about them at the moment. You can see the vagina and the placement of the uterus into the cervix part of the uterus into the vagina, and these are called cervices. We are not going in their details, but something worth mentioning. In front of the rectum and behind the uterus, there is a space. This is an extra space. This is recto-uterine pouch, pouch of Douglas. I remember somebody was asking, and in males, we don't have this thing because there is no uterus. So we have only vesico-uterine pouch. This is vesico-uterine pouch. And in female, this is vesico-uterine pouch. And they have something extra, recto-uterine pouch or pouch of Douglas. And look at the main point, what is for me, what is for you today, the short length of the female urethra and the long length of the male urethra. Prostate is there is no prostate. Female don't have prostate. Please remember this. This is a very important point. And one thing more, which I need to talk about. So, look at it. The opening of the urethra in female, it's very close to the vaginal opening. So there are fair enough chances of contamination. That's why females suffer more. From what? From urinary tract infection, because of the close opening and the short length of the urethra. So these are two factors, short length and the closely placed locations of the vagina and the urethra. They are closely located, one, and the short urethra, and this is straight. And in the male, the urethra is S-shaped. You can see that it's curved, it's not straightforward. And there are wide differences. There is a wide distance among the openings. So here the openings are very close. I'm sure people are fine with this. Let's proceed further. Now we are more bothered for organization of female genitourinary system. We have talked a lot about there already, so I'm not repeating the same stuff which I have discussed. Rather, I like to add on the things. So we are good with that. This is the prostate, this is the ejaculatory duct. We are seeing, because this is a side view, so you cannot see both of them. And you can see the seminal vesicle, urinary bladder, and then this part, the beginning of the urethra, it has two names. People call it bladder neck, and also it's called pre-prostatic urethra, then prostatic urethra. Then this spongy urethra has a bulbar part and a penile part, and then the navicular fossa and external urethral meatus. So now let's add more things here. So we talk about pre-prostatic urethra. So there I'm showing you pre-prostatic urethra, and you can see these, there are sphincters. They are really responsible for controlling. And then we have prostatic urethra. I can show you, this is the part of the urethra which runs through the prostate, that is the prostatic urethra. It is the widest part of the urethra. Then the membranous urethra. Where is the membranous urethra? Is present between this muscle. And this part, this tiny part of the urethra is called membranous urethra. It is the shortest and the most delicate. It's very delicate. A very small amount of, a little trauma can cause it a significant damage here. Then the bulbar urethra. So I told you the spongy urethra is divided into a bulbar urethra and a penile urethra. So bulbar urethra, this is the bulbous portion of the penis, and is a portion of spongy urethra. And this part is very susceptible to be damaged when some gymnast is falling on the bar like this. When the gymnasts are jumping, doing their things, if anyone falls like this on the bar, or somebody is riding a bicycle and you slip from the seat, you can land up on the bar. So there is fair enough chance of damage occurring to the bulbar urethra. We call it straddle type of injury, straddle injury. This straddle is a very pertinent word which is connected. You remember when we talk about falling on an outstretched hand, so we were always thinking of colis and all those things. The same is applicable here. This straddle injury is connected to the bulbar urethra, and we should know the bulbar urethra is part of the spongy urethra. So you can see that this transverse part of the urethra, the beginning after the membranous urethra, we call it bulbar urethra, and then it becomes penile urethra, and this is the longest part. Let me say it again. This is the widest part. This is the shortest but most delicate part, and this part, the bulbar urethra, is prone to tear in straddle type of injury when somebody fall on a bar, no matter how. So prevent that. And if somebody is coming to you, and if you are at the attending physician coming to you with a history of a fall on that, and having always looked for, ask, your next question should be how about your urination and all those things. So that will connect you, and you should be highly suspicious of this type of problem. Okay. And then I told you the last part of my spongy urethra, we call it penile portion of the spongy urethra, and this is the longest portion. Longest portion, shortest portion, widest portion, and delicate portion. And this part is connected with what? With a tear on a straddle injury. I have explained what is a straddle injury and why it happens. And it's something, if somebody who's performing these things should be cautious, then it will not be happening. Now, just a quick recap. Urinary bladder, pre-prostatic urethra, prostatic urethra, you can see that structures are opening. There are so many things opening. I'm not showing you at the moment. This is the membranous part of the urethra, and then this is the penile urethra, but it is written here, whole thing is a penile urethra, but this should be read as what? Spongy urethra. And this much portion is the bulbar urethra, and this portion is the penile urethra. So these terms are quite overlapping. You'll find in different openings in different ways. So don't get confused with those things. Let me bring one more topic here. Somebody was asking me about last time. You remember when I was talking about the blood supply of ureter, I said in male and female. So these are little bit, don't go into these discussions. Simply remember, that's why I posted again, that what should be expected from you if somebody asks you what is the arterial supply of the ureter. So that I have rewritten in the discussion forum. Open and see it again. So now I was talking about the urethra: pre-prostatic, prostatic, membranous, bulbar, penile, and then it ends. Before ending, it becomes dilated. That is the navicular fossa, and then this external urethral meatus. It looks like very wide, but this is again a very narrow point. And usually the people present with the stones, they're stuck at this place. If the stone is stuck in the urethra, usually this is the location, and you can see the patient. The stone is visible just at the external urethral meatus, and anybody can go in temptation. Oh, I can scoop it out. No, that's dangerous. That's disastrous. Don't get into those temptations if you are ever handling these situations. Anyway, in our upcoming slides, so this is overall that what we will be learning today. Okay, guys. So now let's take a quick section and we can just recap what we have learned. So I need not to say again because it's all visible here. So now, one thing which we didn't mention previously, and now you can see that at the beginning, in the level of pre-prostatic urethra or bladder neck, we have these sphincters. These are the special muscle. These are called internal urethral sphincter. We need to be good about these sphincters. Coming that, then what you can see here, the opening of the ureter. And then, can you see there? I have tried to shown you something here. This is called the trigone. This is the trigone area. Half of it is being shown because it's open. And now there I have placed the prostate gland. And now you can see the prostatic urethra. And these are the different openings which opens into the prostatic part of the urethra. And then it continues as the bulbar urethra, and then vice versa it goes. So this is the prostate gland. Everybody should see it. And then you can see this is the seminal vesicle. And then this is, I'm showing you now, ejaculatory duct. So this is not, this is a utricle thing. This is the ejaculatory duct, which opens into the, runs through the prostate and opens, joins the, which part of the urethra? Prostatic urethra. Excellent. Okay, and this one is the seminal colliculus. Another name for this raised area, we call it verumentanum. I'll be talking about it shortly, not now. And then this is the prostatic utricle. We have so many ducts which are opening in the prostatic urethra to pour the prostatic secretions into the prostatic part of the urethra. That's their job. And then this is, you are looking at the rectum. This green or white thing is the perineal body. And then we can see the retrovesical or retroprostatic fascia. We are not talking about these fascias today. There are so many, but I'm avoiding those. But now you should see that the external sphincter is located somewhere here. The external urethral sphincter is located here, and internal urethral sphincter is located here. You remember when we were learning about urinary bladder? I have, if you listen, if you watch the video, there I have shown to you the nervous control of the urinary bladder and how these sphincters are working and what nerves are controlling. I will probably make a short video on that, and I'll be uploading in the YouTube place. Now you can see that I have highlighted something here, and this is what I have highlighted: prostatic plexus of veins in the retropubic space. If you don't know the name of RITS, it's okay. This is the retropubic space behind the pubic bone. But this venous plexus is very important when and where? When we are handling the prostate gland for various surgical procedures. Okay, going further. Now the parts of the male urethra. One, I think you can answer now. You have seen it. So pre-prostatic, excellent. Number two, prostatic, excellent. Widest, we know it. You can see number three, membranous. Number four, bulbar. And number five is the penile. Remember, this bulbar and penile, they are the divisions, they are the parts of the spongy urethra. So we are good, and I'm sure everybody should be connected. Who's widest, who's delicate, who's shortest, who's prone to this injury, and who's longest. These things will be helpful. You'll see them. What is the blue on the left? This blue? Yes. So this is the dorsal venous vein. I'll be talking about it. We are not doing repro block at the moment. So we'll be more concerned about these things when we'll be talking about, you know, these penile stuffs. We are not talking here. We will be confined today only to the prostate and urethra. We'll not be going into penis or the female counterparts. Okay, guys. So now this is the gland is here, bulbourethral gland. If you don't know about it at the moment, it's fine. But remember, there are so many glands which pour their secretions into the urethra, and this is one of them. Now, same revisit on the male urethra, and just now focus here. We know this bone, we know this structure, we know this is peritoneal cavity, we know rectum, we know urinary bladder, and we know the urethra. We know its different parts. We are good with that part. Prostate, we are good with that. Now parts of the urethra we have just gone over. So simply we have said what? Now spongy will be bulbar and penile. We are good with that. So that has been written here. The spongy urethra comprises of bulbar and penile. Bulbar part is more concerned with the straddle type of injury. It lies horizontally, and the penile part is the longest part, and it usually in the vertical location. But now we need to know more. Navicular fossa, we talked about it. External urethral meatus or orifice, we talk about it. Now, can you see the urethra? When it reaches the place where we call it bulbar urethra, it shows a bend here, and I put a green circle here. So that is, this green circle is the first bend. And which place? when the urethra from the membranous part going to the spongy part. So the bend is occurring when the membranous urethra becomes spongy urethra. And of the spongy urethra, which part? The bulbar part. Are we good with that? And there is another bend. There is another bending. And when this bending is occurring, when the bulbar urethra becoming spinal urethra. Okay? There are different terms which has been used, but simply for your understanding, we call it root, we call it body, it's okay. So now these bends are important. When we are inserting a tube, when we need to insert this tube, when somebody has a problem in passing urine, there are so many things. I will not going in this detail. This process is called urethral catheterization. There is a rubber tube which has to go. In females, the passage is straightforward, short, so you can insert it without any danger. But in a male, if you have to try, and this is a common practice in the clinical life, you have to insert these tubes. What are those people where you have to insert those tubes? Somebody who is unable to pass urine for a reason. One. Number two, somebody is bedridden, on ventilator during surgical procedure. You want to monitor the output. Somebody is critically ill. You want to monitor the output. So in those situations, we put this tube which stays in the bladder, and then it's connected to a bag, and you can see how much urine has been made in last 24 hours. This is really, really important parameter of well-being of someone's life when someone is sick, in ICU setup, or critically ill, not normal situation. So these two bends, somebody who's inserting this tube it should be very clear in his mind, and he should be able to negotiate. If I forcefully push this tube, I may danger, I may rupture. Remember, urethra can be ruptured anywhere. But there are certain places which are more prone, but it's not simply saying, oh, urethra can only rupture here. Urethra, you can rupture. It's up to you. If I want to rupture here, I can. I want to rupture here, I can. So it depends on how much trained I am. But these two curves should be, because this is not straight. It is straight, fine, but we should negotiate this curve. Then this is straight. Then we should negotiate this curve. These are more technical points, but just I mention here that you should be knowing about them. Now, this gland, we talk about it. But my main focus is today internal urethral sphincter, and you have seen its location. Where? At the bladder neck, pre-prostatic urethra. At the bladder neck, that's the location of the internal urethral sphincter. And they are made up of smooth muscle. They are not in your control. They are involuntary. And who's controlling them? They are controlled by autonomic nervous system, sympathetic and parasympathetic. Then we have this was my internal urethral sphincter. Now you can see here I have someone else, and this someone else is the external urethral sphincter, and that is made up of skeletal muscle. They are voluntary. We talk about these sphincters when we were talking about innervation of the urinary bladder. And who's controlling them? Pudendal nerve, who's a somatic nerve. So somatic nerve controls the external urethral sphincter, and they are made up of skeletal muscle. And the autonomic nerves, they control the internal urethral sphincter, and they are made up of smooth muscle. And their innervation is being controlled by the autonomic. They are not in our control. And the external sphincter is in our control. Pudendal nerve, which is an example of a somatic nerve, controls this external sphincter. So you can control your urination at this place, but this is beyond your control. When it happens, we'll be talking about it shortly. We need to know. We'll be spending time on these concepts. Is that clear so far? Any concern? I love to chat, but it takes, yeah, it's clear. Thank you very much, because I have a lot to cover. Okay, guys. So I brought up here the concept of sphincters, and I'm showing you a male example and a female example. You can see the long length of the urethra, and you can see the short length of the urethra. You can see there is a prostate, and you can see there is no prostate. There are so many parts. We talk about it: pre-prostatic, prostatic, membranous, bulbar, penile, navicular fossa, and external urethral meatus. In females, there is no such thing, urethra, period. Now, right now I'll be talking about the sphincter. You can see within the bladder 2 ureteric orifices, trigone, same for male and female, there is no difference. Now, male urethra, pre-prostatic, we are good with that. We are good with these labels. Now, this is important. Internal sphincter, internal urethral sphincter. We talk about it is made up of smooth muscles, and it is not in our control. And this one is external urethral sphincter, which is made up of skeletal muscle, and it is controlled by somatic nerves. Pudendal nerve is controlling that. And then female urethra, what we see here, external sphincter is shown, same, under the control, voluntary, pudendal nerve controls it. But what about the internal sphincter in females? There is a question mark. It's not well developed. Structurally, it's there, but it is not well developed. They don't need it. Why they don't need it? That's a big question. Question of today. You know what happens when semen, because we know the male urethra is used for passage of urine as well as passage of seminal fluid, which contains sperm as well. But in a female, this urethra is only used for passage of urine. So the time when we have passage of urine, this internal sphincter has to be open, external sphincter has to be open, and the urine can pass out, no problem. But at the time of intercourse, this internal sphincter has to be closed, because at the time of ejaculation, if the sperm, because we know the ejaculatory duct opens somewhere here. So if this sphincter is not closed, at what time? At the time of intercourse, this semen, which contains the sperm, it will go into the bladder. It will not pass out. Part of it, little part will go forward, but the major part will go in urine. And after completion of the intercourse, when the male partner passes the urine out, he can see his semen is floating in the urine. And this is a problem. This is a condition. It is called retrograde ejaculation. So that's why male needs this sphincter. So at the time of ejaculation, this sphincter has to be closed. If this is not closed, the semen will liable to go into the urinary bladder, and it will not reach where it should reach. So that's why male have a well-developed internal sphincter and an external sphincter. But female, there is no such mechanism, so they only have a well-developed external sphincter. But theoretically, there is an internal sphincter, but it's not functional because there is no ejaculation kind of thing is occurring here. I'm sure this point is clear to all of you. Are we clear? Is there any concern? Okay, thank you. Perfect. You guys are mashallah good. I really love you guys. So now the difference between organization of male and female urethral sphincter. So you can see that we have talked about it. This is the male model. This is the internal pre-prostatic part of the urethra, bladder neck. You can see the organization of the internal sphincter. You can see the organization of the external sphincter. And then you can see the urethra. You can see the opening of the ejaculatory ducts into the prostatic part of the urethra. And then if we talk about the female model, there you can see there is no internal sphincter, but there is only external sphincter, because there are no ejaculatory ducts. And you can see that how closely these two openings are located within the vulva. You can see the opening of the urethra, external urethral meatus in females, and the opening of the vagina. Okay, guys. So now we'll be talking about what is the difference between internal and external sphincter of a male urethra. We have talked about it. Just a quick recap. Surrounds the internal urethral orifice. We agree to that. And external surround the membranous part of the urethra. So we can see the location. So location is this part. Derived from bladder musculature of trigone region. So internal sphincter come from the trigone, and this is derived from the sphincter urethra muscle. And who's controlling the innervation? T12, T11 to L2. This is the sympathetic. And then for the externals, we have the, which nerve is controlling here? Somatic, that is the pudendal nerve. Don't put parasympathetic here. And then this is internal sphincter is involuntary, external sphincter is voluntary. I'm sure these points are clear to all of you. Is this point clear? Guys, these are important. We love to ask these questions a lot. So be very clear about these concepts. Thank you, guys. Okay, so let's proceed further. Now, parts of the male urethra. A male is standing here. We made a sagittal section. You can see how the vas deferens is going and connecting. You can see that it's opening joining the seminal vesicle, making this ejaculatory duct. They are connected to the prostatic urethra. Rest we talk about it. This is another image. You can see that from the testis, the journey of the sperm from the testis through the vas deferens, through these ducts, seminal vesicles, ejaculatory ducts, and they are opening in the prostatic urethra. We are clear so far. And now, why I'm bringing this image here? Just because my next slides are connected to this concept. Be good with this schematic picture. This is the urinary bladder. We know about prostatic urethra, membranous urethra, bulbar urethra, penile urethra. There is no rocket science here. We know this elevated part, we call it verumentanum. These are so many ducts here. So we have internal sphincter at this place, external sphincter at this place. Are we good? Now we are going forward. So this is, I'm trying to develop something. What I'm trying to develop, I'm trying to use this information here. So this is an X-ray. This is not a plain X-ray. This is a contrast material which is injected from the external urethral meatus. This is, you can see that the urethra is being highlighted. This is a real image. This is not a drawing. And you're looking from the right side. We call it cystourethrogram or urethrogram. Now you need to identify the different structure on a given X-ray. Nobody will be asking you on a picture. So in this bladder neck or pre-prostatic urethra, this raised area, verumentanum, prostatic urethra, membranous urethra, bulbar urethra, and the penile urethra. And this much information is required to understand if you encounter any abnormal thing. Usually we don't ask clinical things in that. We only appreciate, we only expect from you that you should be able to identify these different parts of the urethra on a given radiograph. And this radiograph at the moment I'm showing you is called urethrogram, because we have injected a contrast in the urethra and then it has been highlighted. You can see the contrast has filled up the urinary bladder and we can visualize everything here. Now, on an X-ray, you can see that the different parts and their labels, I have just talked about it, and you can connect to that. I don't think there is any rocket science. Everybody can understand. This is just mix and match to help you to understand the location of different structures on a urethrogram. So be good with the urethrogram. And now, same effort has been made. So I have colored the things here. I've used this image. I didn't color it. I'm using this image. Somebody else did it. So you can see that the urinary bladder and these different parts and the urethra has been painted, so it will be helpful for your understanding. I'm sure it's clear. So same thing, we talk about it already. And now female genitourinary system. So there is no prostate. There is no prostate. We talk about this. We talk about this. I don't see any question which is here for bothering us. So blood supply of the urethra in female, these are the sources. In male, these are the sources. Guys, I'm talking about main common thing. If you open up so many books, you'll find a little bit up and down. Don't bother for that. If you know this much, you're fine. You're surviving well, very well. You're A. Now, coming to the second phase of our learning today, and this second phase will be focused on something which has been shown in this image, and that is here. And what is that? We are looking at the prostate. Now we'll be talking about prostate gland in details. So this is, I'm showing you the prostate gland without any further delay. So you can see its close association. It is placed at the bottom of the, the urinary bladder. You can see the seminal vesicles. They are opening. Sorry, the seminal vesicle. You can see the ejaculatory, vas deferens. I cannot show you at the moment. Guys, I have uploaded short videos, YouTube videos. So you can watch on the channel. Those are there. So now the location of the prostate, we are good with this. There is no rocket science. We talk about it. We talk about this. And we talk about, no, we didn't talk about that. So you can see inside the urinary bladder, the openings of the ureter, intrauterine bar, trigone. Now, the prostate, this is the pre-prostatic urethra, and this is the prostatic urethra. So can you see this ovoid structure? This is some verumentanum. And you can see these are the two openings of the ejaculatory duct. In prostatic utricle, and you can see there are numerous openings. So these numerous openings are bringing the prostatic secretions within the lumen of the prostatic urethra, and this is, they'll be passing along with the sperms at the time of ejaculation. Are we good so far? So now, The prostate, if we look at structurally, it is made up of, it has glands and it has fibromuscular. So this prostate gland is partially, it is made up of fibromuscle, muscles, fibers, and gland. So three ingredients: fibers, fibrous material, muscular stuff, and glandular part. So they are making, histology people will be talking in more detail. It lies beneath bladder, we know about it, above the urogenital diaphragm. Penetrated by the proximal urethra, we have seen it. Normally, if you look at it, it looks like walnut. Height is less, width is more. If you are in doubt, get a walnut, not the broken one, a complete one, and just try to see it. This is an approximate measurements in centimeters, not in inches. And then what female? So in female, their prostate, they don't have a prostate, but they have a special gland. They are the, Paul will be talking about it, the female homologues, and these are the group of paraurethral glands, and these are glands of Skinny. So these are the counterpart of the prostate. They are present in females, but they are not working like prostate. They are different. And then prostate, why we need it in men? It provides 30% of the volume of seminal fluid. There are so many factors, I'm not going in details. Otherwise, this is one of my area of interest, you know, infertility, Tifl and Abib, everything. There are so many things here, but let it close. Not needed for you today. Now, if you look at a section of a prostate, let me orient you on this image. This purplish thing is the prostate. And there you can see this H-shaped thing in between is the urethra. This is rectum. And this is in front, the superficial dorsal vein. Somebody was asking me in that thing, what is that blue thing? This is that blue thing. And you can see that this is the prostatic plexus of veins. So simply you should remember that. On the sides, we have the levator ani muscle. Now let's see. Can you see that prostate, the outer margin, there is some layer. What is that? So this is, what is this? This is a capsule of the prostate, and I call it a true capsule. If I say true, there must be someone false. Where is that? So there you can see at the outskirts, this is my false capsule. So prostate gland is surrounded by two layers, two dense fibrous layer. One adhere to the parenchyma of this gland, and one is just apart, and in between I have this venous plexuses, abundance of venous plexuses, they surround. And one is called the true pelvis, one is called the false pelvis. Are we good so far? Okay, so now true capsule, what it is, and a false capsule, what it is, and what lies in between. Guys, this is a must-know type of information. The covering of the prostate, same like covering of the kidney. You remember when we were talking about the covering of the kidney, we talk about a renal capsule, perinephric fat, renal fascia or gerotous fascia, and paranephric fat. So when somebody will ask you about the covering of the prostate, so it is covered by a true capsule and a false capsule. And what it is made up of, you can read it here. I need not to talk about it. But this is an important thing. You must not forget it. So now, what I'm doing a rectal examination. Why I'm doing a rectal examination? Because prostate is not something which you can feel. Like you can feel your liver. You can feel your stomach. You can feel your thyroid. You can feel so many things. But prostate is something which is deep. So to feel a prostate, you have to insert the finger from the anus into the rectum. And you can see with my digit, I can really, through the wall of this rectum, I can feel on the surface. And this is a really, really important test when you will be doing abdominal examination. This inserting a finger into the rectum of the patient, this is one of the integral part. And trust me, if you are asked in the finals, do an abdominal examination, and if you have not done a rectal examination, you will not be considered that you are done everything right. So you are missing out something. So just we can see in this image, this is a section. So this is the rectum. So by putting a finger here, you can easily palpate on the surface of the prostate. And so many problems we can just learn by just inserting a finger into the rectum. This is the really important. And what we call it? We call it digital rectal examination. Where is it? Why we call it digital? This is your digit. So that's why it's digital. We are always excited, oh, this is a digital device. What is digital? We are not moving it. We are just touching it. So that's the digital. And we call it in clinical terms, DRE, a very commonly used term, DRE or digital rectal examination. I hope we are clear for this. This is an important thing, and it's really important for looking into when we are suspecting somebody is having a prostatic problem. When you're dealing with someone who has a prostatic problem, don't ignore this part. This is really important. Now, let's look at in detail about what? Prostatic urethra. Prostate, because when I look into the prostatic urethra, I'll be covering about the prostatic urethra as well as the prostate. So we can see very clearly, very obvious thing which has been explained. So let's label it. What do you think is this? Guys, it's your time to talk. Talk. Internal sphincter. Excellent, mashallah. Okay, going further. Internal urethral sphincter. And what about this? I just mentioned in my previous, I know the name is difficult. Verumontanum. Excellent. Seminal colliculus verumontanum. What about these? Ducts. Which ducts? Ejaculatory ducts. Excellent. You guys are pros. Opening of the ejaculatory ducts. And what about this? External sphincter. Mashallah. I'm glad with the speed of you guys. Outer sphincter. Faris, you're right. You guys are good, mashallah. So now you have seen quickly what you have seen. The things which opens in my prostatic urethra. Can you see these numerous branching pattern? These are so many prostatic ducts which have no names. And these are abundant openings. And all of them, what are they doing? They are pouring prostatic secretions and they are rich in fructose. So fructose is usually coming from here, and that will be part of the seminal vesicle, and it's one of the integral part. So I'm sure everybody is good with that. Okay, going further. So you are looking in another view. Look at the different ducts which are approaching, which are present within the parenchyma of the prostate, and this is the prostatic urethra. And you can see that how and where they are opening. This is the ejaculatory duct, which is, white, grayish white. This is the utricle and rest of the opening. And you can see in a section. So look at it in between. This is the prostatic urethra, and so many duct systems have been opening here. And you can see here these two are nothing but the ejaculatory ducts. Are we good so far? Okay. Now, what are, guys, in older people with older terminologies, older books, people were talking about lobes of the prostate. Now that era is gone. The word lobes has been replaced by zones because this is a more acceptable term in clinical understanding. Even Gray's Anatomy writes, after 20th week of development, the concept of lobes is gone and it is replaced by zones. So let's see. And this is really important. When we talk about prostate, you need to be good with the zones. So now let's bring a simple model. So this yellow structure is the urethra. And this is I'm showing you here symbolic. And look at it. These are the seminal vesicles. And these seminal vesicles, you can see there, ejaculatory ducts, and they are opening. I'm not showing you prostate here. I'm showing you the structures. I'm making a prostate. It's not complete yet. So there is one core which surrounds completely my urethra, and that core, that substance is called transition zone. So a zone of the prostate, a tissue of the prostate which is present around this tube. Let's say this is prostate and there is this urethra which goes through it. So this is around the urethra, the part of the prostatic tissue which surrounds it circumferentially, we call it transitional zone. Remember this part. Now let's add on. So you can see the same, plus I have added one more stuff which is only present behind. We call it central zone. Then we can see the transitional zone, we can see the central zone, and a big brownish thing. This is the peripheral zone. And last, everything is there. Now the prostate gland is completely located where it should be. Now we can see it. The outermost core is primarily the peripheral zone. Anteriorly, we have a fibromuscular stroma that is not a zone. So ignore it. Ignore it. We are focused with this transitional zone. You can see that this core of the prostatic tissue, it surrounds the urethra primarily. Central zone is just in close contact with the transitional zone. So it's not coming in contact with the urethra. And the peripheral zone is not coming in a big way in close association. So this is in the periphery, so we call it peripheral zone. So to cut short the story, a peripheral zone, a transitional zone. Out of these four zones, what is must know is transitional zone and peripheral zone. The others are just for your infos. But we are mostly all the diseases of the prostate gland. Remember, prostate is one of the major issue for old age in men, one of the leading problem. And a big number of people are affected right across the globe and right from the beginning of the mankind. And you remember, for your infos, in the early days of life, when there was no civilization, the biggest cause of death of males were retention of urine. They were not able to pass urine, and the reason was prostate was enlarged to a big extent, and then they stop passing urine, and that become their main cause of death. And usually in that era, I'm talking about 1,000 years back, centuries back, that was a time if some old person has stopped passing urine, usually people started visiting him. Oh, now he is on an exit journey. But now this is not. The whole thing has been changed. Okay, so let's go further. Now this is another view which is showing you the zones. So just to connect you guys, let's put the labels here so you can see there. The red thing is the peripheral zone, blue thing is the transitional zone. This number 2 is what? Number 2 is the central zone, 4 is the fibromuscular zone. So we are only concerned with number 1 and number 3. Ignore 2 and 4. Are we good? So you can see that the pre-prostatic urethra, prostatic urethra, and then there will become membranous urethra and vice versa. Are we good so far? Any issue? Anything which bothers you? I can see there are 3. Yeah, clear. Okay, good. I like you guys. So now this is the detail. If somebody wants to read, I just inserted it here. Central zone, what it is, how it look like. But we are mostly talking today about peripheral and transitional zone. These are clinically relevant. This is just for nothing. So stay focused with the peripheral and transitional zone. Rather, I should number it 3. Why I make it number 1? Okay, so what we have learned today so far, this is the prostate gland. This is the, what is this? I have not labeled it. Rest is all labeled. We can see the ejaculatory ducts. We can see the external sphincter. We can see the urethra. We can see the seminal vesicle. So what is not labeled, that is important. Transitional zone. You can see that transitional zone is the only zone which is surrounded by the prostate. In the prostate, which is through which urethra passes. So through the transitional zone, urethra passes. That is important. And then peripheral zone, which is arranged at the periphery. So I have tried to map it with the colors, so green for the peripheral zone. And this is the transitional zone. They are important in understanding so many diseases which are connected to that. What are your comments? Is there anything? What is its function? Function of what? Yusuf, you're writing, what is its function? Yusuf, write quickly. Transitional zone, Yusuf, I'm coming to that. My whole rest of the part of my presentation now, for next 15 minutes, I'll be talking about the transitional zone. Don't worry for that. So guys, now, this section, we have covered it. It's a sagittal section. Quickly recap. We are good with these. We're not bothered with these fascias at the moment. We know about internal sphincter. We know about this orifice. We know about this trigone. We know about prostate gland, seminal vesicle, ejaculatory duct, verumentanum, prostatic utricles, rectum. So we are good with this image. There is no rocket science which has been mentioned here. Prostatic venous plexus, bulbourethral gland. Now, I hope everybody should be good. Now our focus will be at this level. Now I'll be talking about, as we grow older, what happens to this transitional zone of the prostate. Your focus should be in this zone in my next coming slide. Guys, if you stay focused for that slide, I think you will learn everything about prostate. Then I have nothing else to talk about it. So just look at it, how it is different. Look at it now and look at it now. Something has been unusual. It has been raised because, and look at it, I'm giving you again. This was wide. There was no elevated part. But due to the enlargement of the prostate, this channel has become narrow. And some part of my prostate gland, some tissue of the prostate gland has been raised. And this core, we talk about it, who surrounds my prostate, the inner core is the transitional zone. So this is an enlargement, a part of the transitional zone which has popped into the lumen of, because this prostate has grown big. You know, at the time of birth, it's a peanut size. And when it enlarges, it's like size of an orange, Portugal, a Portugal. So it goes that big. And if in extreme situation, I remember I have removed a size of grapefruit. That's disaster. So now stay focused here. Some changes are occurring. And what are these changes? Orifice is there. We are good with that. This raised area. So this is the median bar. You can see only with the help of a cystoscope. So there is an enlargement of the transitional zone, which is also called, old people call it median lobe. Transitional zone, median lobe. So as a result of that, we have a condition, prostatism. Old people called it prostatism. Now we call it lower urinary tract symptoms, LUTS. So what are the anatomical changes which are responsible for getting this prostatism or lower urinary tract symptom? So the changes are, I'll be labeling them one by one for you. So number one, you can see it. We talked about it, that the transitional zone or the median lobe of the prostate protrude into the bladder, causing a bell valve effect over internal urethral orifice. So this is happening. So we have created a valve-like thing. This is first indication. And because of that, the channel is narrow. The urethra has become narrow because prostate enlarges. So now, and you have created some obstacle. So the bladder will not empty himself out in a nice way. So someone who's suffering from this prostate will not able to complete. See, right now, anybody wants to pee, go and you finish in a minute job. But older people, you might be noticing your grands, some of them, when they are visiting their toilets, they are coming after maybe half an hour and this and that, and you're, what the hell is going on? Poor them are suffering. Don't be angry on them. Poor them are suffering and they are in a problem, and the problem is their prostates have been enlarged if they're spending more time, and because of that, this is enlarged, the channel has become narrow, so urine is not coming with a pressure, it is coming drop by drop. That is happening. So you can see there is an obstruction. This channel is becoming narrow. So intravesical pressure during attempt void. So bladder exerts more and more pressure. Detrusor muscle acts more. When we use more muscle, muscle become hypertrophied. Like when you do workouts, you can show your muscle, oh, I have raised my biceps. So same is happening. So there is a thickening. So too much pressure has to be exerted from the bladder so it can empty it out. So this is first thing which occurs with this first change. Then the second change, what is the second change? Distortion. So internal sphincter is destroyed. So now I have not a good control on my internal sphincter. So there is a chance of leaking of urine. The internal sphincter has been distorted. Incompetence. Dribbling is the word for urine is not coming with a pressure and there is an incompetence. Incomplete. Sphincter incompetence. So incompetence means the sphincter is not working the way it should work. Then distortion of the prostatic urethra. So progressive obstruction. It's not overnight, but slowly and slowly the flow has been decreased. Now urine starts pulling up here. So when in the trigone area, when the urine stays there, every minute you get signals there is some urine. You go in the toilet, you cannot pass it because it stays here. So it's difficult. So these people are the one of the major disaster in their life which occurs is they have to visit their toilets in the daytime. You know, you may not notice it, but in the night when they're sleeping, every minute they have to go to the toilet. So if an older person wakes up 2 3 times in the night, then his sleep is gone. It's not like young people like you. So the stasis of the urine, collection of the residual urine. When the urine stays here for longer period, bacteria can grow, infection, everything will start coming up. And then the last thing, dribbling, because there is urine is stored there, this sphincter is gone. So now they you know they can see some drops of urine has been passed out, and their clothes become dirty. Older people, prayers, everything is affected. They cannot sleep. So sleepless nights, clothes becoming dirty. Every minute they're passing drop of urine. While even they're praying, they can pass some urine drops, and they are totally miserable. So don't blame our grands, because poor them are suffering, most of them. I don't have time, otherwise I can talk a lot about things, and really they need our help, they need our support. So be nice and kind to them always. Now, what we were talking, a normal bladder, flow was good, but when this is enlarged, the channel become narrow. For your comparison, so urine is unable to pass, so is returning, and a time is reached, the passage of urine stops. That's a disaster. Then you have to insert a tube. It is difficult to insert a tube. Now it's a time for surgery. Before this happens, you can give tabs, you can do something, but here you only have to go for a surgical maneuver. That's an important thing. So a quick recap: prostatism, lower urinary tract symptoms, anatomical backgrounds. I have explained everything here, 1 to 5. Remember these points, they are good to know. And you can see that normal, you and me, we are like this. But when we'll grow old, we may get this problem. I'm not saying every old man gets it, but majority of them got it at certain stage. So now look at it. This is what I was trying to show it to you. Look at it. Look at the urethra. It has all been compressed. Compare and look at it through a cystoscope. We can see something, a bar has been raised. And who's this bar? This bar. A cystoscopic view, Manazir. And you can see a bladder. The wall has been destroyed. Everything is distorted. Look at sphincter is gone. All those signs of prostatism. Now what is the solution? So this is called benign prostatic enlargement, BPE, BPH, so many terms has been used. So this is a benign disease, unless it's not a cancerous disease. Nobody dies of that. It's not a cancer, but people die of obstruction, not of this disease. But this disease leads to that. Look at it. This is a different scenario. This is a prostatic cancer. Now look at it. We talk about the peripheral zone, you remember? So peripheral zone is the hub for where we have cancer of the prostate. So the prostate on a field, when we do a rectal examination, on a enlarged prostate, BPE, you feel a big prostate as compared to a small prostate. But on a cancer of prostate, you may find these nodules. You may find it is very hard. Guys, remember 3 terms here. Feel your tip of the nose. That is firm. This is firm. Lobule of your ear, this is soft. And your forehead, this is hard. Now, if prostate feel like your tip of the nose, this is a BPH, most likely. If it feels like your forehead, this is a cancer of the prostate, most likely. I'm not saying 100%. We have to do some more tests. And if it is rubbery like your lobule of your ear, this is prostatitis, inflammation of the prostate. So many men suffer from that. It's a very bad disease. And usually, who are getting this disease? Those who are in not good practices, those who are involved in adultery and all those kind of things, they are getting these problems, prostatitis, mostly. I'm not saying all those who have prostatitis, you start suspecting them, they are in bad relations, no. But mostly, and this is very disastrous problem, and this infection, it takes ages for them to get recovered, and they suffer a lot. So look at it. This is the status of the cancer of the prostate, but it is in the peripheral zone. So the flow usually is not bothered. They can pass urine, but they have other symptoms. Their weight decreases, like the signs of cancer. They develop. Usually it goes unnoticed, but then they develop body pains and all those kind of things. And then and most of the big people of this world, they usually die. If you look at their cause of death was cancer of the prostate. So now this slide is important to understand these diseases, so we can quickly go over. We are good so far. There's no new term I have used, just on a section. The same thing on a section, what we were learning before. This is the sulcus. Now, this is the transitional zone. This is the transitional zone. Now, benign prostatic enlargement. So this, if there is an enlargement in this zone, this part of the urethra will be narrowed down. So patient will have all these BPH thing. Benign prostatic hyperplasia, hypertrophy, enlargement, so many terms used. So this green thing is indicative of that problem. So this, if you know this much, enough. And now the cancer of the prostate, we all know, is in the peripheral zone. So this red thing indicates the cancer of the prostate. And if you know this much about BPH and this much about prostatic cancer, you are done. You need not to go into other resources or anything other than that. It has a lot. It is connected with so many things, PSA is raised, biopsy, so many things. But if you know this much, the benign disease in the transitional zone and the cancer lives in the peripheral zone. This is good for you, for your understanding. Now, treatment is surgery. Guys, for the prostate, don't forget this red box. This is really important. This is about how the lymphatic spread in different areas. And now this is the treatment. This is a gold standard for those who are suffering from the prostate. You can see that on an endoscope on your screen, it appears like that, but this is the reality. We insert this camera through the urethra into the bladder, and you can see with this loop, we can just chop the pieces of this prostate gland, and I can show you. Here you can see that the process, we are just clearing it apart. Look at it before. When somebody present with the BPH, this was the situation. Look at it, how narrow was the urethra. And after the resection, when it is completed, look at it, there's a wide enough open channel. And this is after this TURP, transurethral resection of the prostate. This is a gold standard. It is even practiced today. There is nothing, people use different modalities. I'm not going in those details for you, but simply remember, this is the last remedy, the surgery. And this is good, and it has a widely acceptable worldwide. There is no rocket science here. So look at it before, when somebody is suffering from prostatism, BPH, and after the surgery, this is a situation, and now this person can pass urine. There are a little bit compromises, but this is what somebody needs to pass urine when there is a desire of urine passage. Now, if somebody don't get it done, an enlarged prostate, if you don't get it operated, if you wait for something happening, guys, this will end up with disaster. Look at it, bladder is distorted. Look at it, ureter is distorted. Now this is a hydroureter. The sphincteric mechanism is gone. Now urine is stayed filled up with the urinary bladder. Look at it, these are the endoscopic views. So now the ureter continuously, the urine stays there. Even the hydropelvis and the kidney is being destroyed. Look at the cortex is gone, and the end is the renal failure. We call it azotemia. This we need to prevent. If somebody get this surgery done, this surgery done may not end up with this disaster. That is really important, and people need to know about it. And then I talked about, I use a term Foley's catheter, so I have to show it to you. This is how it looked like. There's a balloon. There you don't see a balloon. This is a female when we are inserting this tube, and this is in a male, like when it goes in the bladder, male or a female. So when we inflate from this port, we inject fluid. So this balloon is there. So now it can stay, and it can evacuate urine till you are done. So this you need to know about these different features. And now this is another picture. I'm showing you different openings of the urethra. It is possible. You may find some people like that, and this condition is called hypospadiasis, and this is a very, very important thing, and people should be knowing about it. So guys, with this, I end up my presentation. I have a video, but I think I will upload it. I don't have time for that. I'm ready for your questions. So how does normal prostate feel like? Normal prostate feel like it is in between firm to soft. When it is enlarged, when it is big, it becomes firm. But before that, you can feel the pinna of, the nostril, the external nair. This is not the tip, but the nair. This is a normal prostate. This is an enlarged prostate. This is a cancer of prostate, and this is prostatitis. May you please explain retrograde ejaculation again? Retrograde ejaculation, can the cone stuck in the bends of the urethra? Yes, it is possible. But ultimately, if it is through from there, then it will be retrograde ejaculation. Basically, Yazid, primarily what happens, retrograde ejaculation in a male, because male has an ejaculation. So if the internal sphincter is damaged, is distorted, is not working, so the semen, instead of going to the external urethral meatus, it start going back into the urinary bladder. So a male need both internal sphincter and external sphincter active and functional. Can you repeat what is the name of the condition in the renal failure? Azotemia. Let me write it for you. Are we good? Anything else? Okay, guys, thank you very much. So I think I will plug in that video in either in YouTube or on your lab resource material, so you can watch it. It's very nice short video which is explaining about what happens in the BPH and what happens in the prostatic cancers. It's a very nice small animation. Why do patients with stasis of urine use to restroom mostly during night? Because there is some urine stays. You saw that because of the raised portion of the enlarged prostate, some urine continuously stays in the trigone. So now it continues bugging the trigone, and the trigone is sensitive. The signals are going, the sensory signals are going to my brain, and the command is coming, there is some urine in the bladder, go and finish it up, go and finish it up. So your sleep pattern is disturbed. That's why, and this going so many times in the toilet, visiting so many times the toilet, is called nocturia. So guys, I think with this note, I like to end. I don't see there is any other question. Bye-bye, stay safe, and hope see you boys today in the labs and girls on Wednesday and Thursday. Inshallah, we are there for your help.